Nursing students are routinely handed a list and told to memorize 30, 50, or 100 different medications. They drill flashcards on generic names, side effects, and dosages until the facts blur together. But a flashcard does not save a patient. When a patient's blood pressure drops in the middle of the night, recalling alphabetized side effects takes too long. Rote memorization fails under the pressure of real-world clinical care. Safe practice requires a different approach. True clinical judgment means predicting a medication's threat before you ever push the plunger on the syringe. We visualize this by organizing our essential medications into a 4-quadrant matrix: coagulation, hemodynamics, renal, and endocrine. Identifying a drug's cluster instantly reveals its danger profile. You stop seeing 30 distinct medications and start seeing 4 predictable biological mechanisms. Understanding these exact mechanisms is how a nurse knows instantly which specific lab value to draw or which vital sign to check before a drug is administered. The first cluster governs coagulation. The systemic threat here is straightforward. By preventing dangerous clots, we risk inducing active, uncontrolled hemorrhage. We monitor 3 primary medications in this group: heparin, warfarin, and clopidogrel. This table compares their monitoring requirements. Column 1 shows heparin. It acts quickly, often given via IV, and requires strict monitoring of APTT, a blood test that measures the seconds it takes for a clot to form. It also carries a unique risk of HIT, or heparin-induced thrombocytopenia, a dangerous drop in platelets. If bleeding occurs, the specific antidote is protamine sulfate. By contrast, column 2 shows warfarin. This is an oral medication that relies on a different lab, the INR, or International Normalized Ratio. Because warfarin decreases vitamin K-dependent clotting factors, a patient's dietary vitamin K intake can swing their lab results. If the INR spikes too high, vitamin K itself serves as the antidote. Column 3 is clopidogrel, an antiplatelet that prevents platelets from sticking together. Unlike the other two, it does not require routine clotting lab monitoring, like an APTT or INR. It is often prescribed after a cardiac stent is placed, meaning a missed dose can lead to a blocked artery. Patients on any of these 3 drugs require universal bleeding precautions. Nurses must teach them to use soft toothbrushes, electric razors, and to immediately report signs of internal bleeding, like black stools. Managing blood thinners requires a strict, data-driven balance. The margin between preventing a fatal clot and causing a catastrophic bleed is entirely dependent on tracking these specific labs. The hemodynamic quadrant groups cardiovascular medications and diuretics. Diuretics control blood pressure by pulling fluid off the body, but they do so by manipulating electrolytes. This graphic demonstrates the primary risk. When furosemide and hydrochlorothiazide flush water out of the system, they drag potassium out with it. This rapid loss creates hypokalemia, severely lowering blood potassium levels. Spironolactone does the exact opposite. It spares potassium while removing fluid, meaning potassium levels can spike into hyperkalemia, threatening heart rhythm. These fluctuating electrolyte levels directly impact the heart's electrical system, especially when a patient takes digoxin. A low potassium level drastically increases the risk of digoxin toxicity. Because of this risk, there is a strict clinical checkpoint. You must assess the patient's apical pulse for 1 full minute before administering digoxin. You are listening for bradycardia and checking for physical signs of toxicity, like complaints of yellow-tinted vision. Metoprolol operates in this same quadrant. It is a beta blocker designed to slow the heart rate and lower blood pressure. Cautionary, but metoprolol carries a hidden danger for diabetic patients. When blood sugar drops, the body's natural warning sign is tachycardia, a rapid heart rate. Because metoprolol artificially keeps the heart rate low, it masks that critical warning sign, leaving the patient unaware they are hypoglycemic. Effective cardiovascular care treats the heart, the kidneys, and the endocrine system as one interconnected hydraulic and electrical network. The third cluster contains the heavy hitters of renal and toxicity risk: gentamicin, vancomycin, acyclovir, and lithium. This diagram illustrates the dual threat posed by powerful antibiotics like gentamicin and vancomycin. They are both highly nephrotoxic and ototoxic, meaning they can actively destroy both kidney function and hearing if drug levels climb too high in the blood. Vancomycin requires strict administration protocols. If you infuse it too rapidly into a vein, it triggers a massive histamine release known as red man syndrome, causing severe flushing and redness across the body. Acyclovir is an antiviral, but it carries a similar renal risk. Administering it intravenously requires aggressive hydration. Without enough fluid pushing through the system, the medication crystallizes inside the renal tubules. Lithium, a mood stabilizer, operates on a slightly different clearance mechanism. The kidneys rely heavily on the body's sodium balance to process it safely. If a patient on lithium gets a stomach bug, becomes dehydrated, or loses sodium, the kidneys retain the lithium instead. The drug cannot clear, and blood levels quickly spike to toxic ranges, causing tremors and confusion. For this cluster of medications, the boundary between a therapeutic dose and a systemic poison is defined entirely by the patient's hydration and renal clearance. The final quadrant is the endocrine system, where we look at glycemic control. With insulin, physical timing is a matter of life and death. This graph tracks drug effect over time. To avoid hypoglycemia, you have to know the exact pharmacokinetic curve of the specific insulin ordered. LISPO causes a steep, rapid spike in insulin levels, meaning the patient must have food right in front of them when it is given. Regular insulin creates a moderate curve. It is short-acting and must be visually verified as a clear liquid before administration. NPH insulin has a delayed peak that hits hours later, creating a risk for unexpected low blood sugar late in the day. Visually, NPH is cloudy and must be gently rolled to mix. Finally, there is glargine. Notice the flab line. This is a long-acting basal insulin that provides a steady 24-hour background effect with no distinct peak. Because of its unique formulation, there is a strict safety rule. Glargine must never be mixed in the same syringe with other insulins. Administering insulin without perfectly aligning its specific peak time with the patient's meals is a failure of clinical judgment. The timeline dictates the safety. There is one final complicating factor that spans all four of these high-alert clusters: the older adult patient. Age acts as a multiplier for risk. Natural declines in renal clearance keep drugs in the system longer, while an aging cardiovascular system increases orthostatic sensitivity, turning minor dizziness into severe falls. A medication like donepezil is widely prescribed to help stabilize Alzheimer's dementia, but in a frail patient, it can trigger severe anorexia, weight loss, and fainting, worsening the physical frailty we are trying to manage. Benzodiazepines like diazepam are standard treatments for anxiety or muscle spasms, but in older adults, they often bypass standard sedation and cause paradoxical agitation, deep confusion, and a massive risk for catastrophic falls. Tricyclic antidepressants like amitriptyline carry a heavy anticholinergic burden. They dry out and slow down bodily functions, causing blurred vision, urinary retention, and dangerous drops in blood pressure upon standing. Memorizing a flat list of side effects doesn't prepare you for these variables. By mapping medications into distinct physiological clusters, you predict the systemic failures before they happen. You stop reacting to emergencies and start intercepting them.